Well, that was a fun question and answer period. Thank you all very much. So our next panel presentation is, I'm kind of excited. It's Practical Genetics for the Otologist, what you need to know. And so I've asked this panel to come together and actually, I gave them a bunch of questions that I wanted to know, and I hope you do too. Anna Kim's going to be the moderator for this session. We've got three distinguished panelists, Dylan Chen, Sharon Cushing, and Eliot Shearer are going to come up and give us an overview, and I'm really excited about this panel.
Okay. All right. Well, thank you for staying to the very end. I assure you it will be well worth it. These are certainly exciting times, not just for our field, but for all disciplines. As a matter of fact, this week, the American Academy of Gene and Cell Therapy, they had their annual conference right down the road, and they reported, of this defect that causes the body's inability to break down ammonia, so you can have lethal levels. At CHOP, they successfully used personalized CRISPR gene editing, and you can see the baby that's healthy and was just discharged home. So I think every week, every month, we're learning something exciting about genetic breakthrough. So today, our panelists have been tasked to provide a practical guide to what we need to know as otologists in this emerging field. We have a terrific panel, starting with Dr. Dylan Chen. He is professor in pediatrics at UCSF. In 2014, Dr. Chen established the UCSF Children's Communication Center, which is devoted to delivering multidisciplinary care for families of deaf and hard of hearing. And he will be reviewing some common genetic causes and the pathophysiology of hearing loss, and he will also cover genes associated with hearing loss phenotype. Our next panelist is Dr. Sharon Cushing. She is professor in the Department of Otolaryngology at University of Toronto and also the director of Cochlear Implant Program at the Hospital for Sick Children. Her research interests include vestibular imbalance, function and dysfunction in children associated with hearing loss and cochlear implants. Dr. Cushing will speak on when should a clinician order genetic testing and when should a genetic counselor be involved. Our last panelist is Dr. Eliot Shearer. He's an attending surgeon at Boston's Children and an assistant professor of otolaryngology at Harvard. He also has a lab that studies genomics of hearing loss with a focus on new diagnostic methodologies. So without further ado, can we have Dr. Dylan's talk?
Awesome, thank you so much. Thanks to AOS for the opportunity to speak here today. This is truly an exciting time in the field of genetics for sensorineural hearing loss. So I'll talk first, going over some of the common forms of genetic sensorineural hearing loss and specifically how we are currently using genetic information to inform sensorineural hearing loss, this connection between the genotypes that we are identifying through genetic testing and the phenotypes that we're observing as a sort of backdrop to the rest of the discussions. Just like to acknowledge everybody on my team, which is who's contributed to the research that you're showing, as well as the clinical care funding from the NIH and PCORI, as well as those disclosures. So childhood sensorineural hearing loss is common. It is the most common congenital sensory disorder affecting about 1 in 500 babies. But that number increases as we go on through childhood. And by the time you get to 9-year-olds, more than half of children with sensorineural hearing loss in later childhood actually developed it after the newborn period. And the majority of these children with sensorineural hearing loss are thought to have an underlying genetic cause. And when I see a child with a newly identified sensorineural hearing loss in clinic, and we see a few hundred of these a year. These are the 5 questions that every single parent asks, right? They ask, why can't my child hear? What's going on? Is the hearing going to get worse? What else might be going on with my child, right? If the hearing is decreased, could there be something else that's affected? What does this mean for my other kids? And most importantly, what can we do about it? And we undergo a number of different etiologic tests to try to identify the biological cause for the hearing loss, so that we can answer those questions. Because most of the time, these children don't come in with an obvious cause from their history or their physical exam. And the 3 core etiologic tests that we do imaging, we do some manner of CMV testing, and we do genetic testing. And the rationale for each of these forms of tests is generally pretty clear. So for imaging, right, depending on the presence of the cochlear nerve or the anatomy of the cochlea, that tells us a lot about cochlear implant candidacy and expectations. For CMV testing, right, if we have a baby with congenital CMV, then we know that we can treat with valganciclovir to either improve or at least stabilize the hearing. But what we don't all understand, and which is evolving all the time, is exactly how we use our genetic testing information, how we use a genetic diagnosis to inform our management and counseling of the families, and that's what I'm hoping we can convey today. So, how do we do these tests? Historically, and this was the case when I was in training, we would do single gene or targeted panels, right? So we would test for a single gene. We'd do sequencing for GJB2, which is the most common cause for sensorineural hearing loss. Or we'd see a person that has Pendred syndrome, and we'd send a panel of genes associated with Pendred syndrome or Usher syndrome. And while these can certainly provide a genetic diagnosis, normally these don't tell us much that is new, right? This doesn't really identify anything that the audiogram and the clinical history doesn't already tell us. The current standard of care is to perform a comprehensive hearing loss panel. And there are a number of different panels. Basically, every genetic testing company out there has a panel. For the most part, they are done via targeted gene capture and massively parallel next-gen sequencing. And these look at about 200 or so known hearing loss genes, both in the coding regions, splice junctions, some mitochondrial genes, some common deletion duplication analyses, and copy number analyses. And this is the gold standard right now. This is covered by insurance by many public insurers and many commercial insurers as well. Where we are likely going is towards whole exome and genome sequencing, which can give us additional information, including identifying novel hearing genes. And the genes that we identify as being involved are many, and I'm going to go over some of these. And we can understand how they function in different parts of the cochlea. Cadherin 23 is part of the tip links that connect the stereocilia on hair cells. GJB2 controls ion flux through the supporting cell network. Otoferlin is obviously an important presynaptic protein, and tecta is an important component of the tictorial membrane. And when we look at the results of genetic testing, we can understand how impactful the genetic diagnosis is. And this is from a study that we did back in 2022, where we looked at about 400 or 500 people who underwent hearing loss gene panel tests. And now we found a genetic diagnosis rate of about 26%. This is actually on the low side. Most other studies have found that hearing loss gene panel testing has a diagnostic yield of closer to 40 or 50%. The reason why we have such a low diagnostic rate has to do with the racial and ethnic makeup of our population, which is a whole other talk. But this is work done by Elizabeth Lau, one of our medical students. But in our study, we found a genetic diagnostic rate of about 26%. About 70% of those were non-syndromic, roughly stable hearing loss. And I say roughly stable because if you look hard enough, almost all forms of genetic sensorineural hearing loss can have some signs of progression over many, many decades. And the two most common causes of these are GJB2, which encodes for connexin 26, and stereopsilin. And the initial thought with some of these is that, okay, fine, you just identified a non-syndromic stable sensorineural hearing loss. You know, that's sort of what we assumed from the beginning. What new are you learning? And I can tell you that nearly every single family that I get a diagnosis like this on, and I can tell them, you know what, I know that your child's hearing loss is due to a stereopsilin deletion or GJB2 variant. And I can tell you that there's no reason to think that there's anything else going on with your child's vision or heart or thyroid or kidneys. And I can tell you that it is very unlikely that your child's hearing is going to rapidly progress in the next 5 years. That provides a huge amount of reassurance for the families, and it can help them get over that hump of proceeding with their lives and their children's hearing care. 30% of these diagnoses directly affected management in multiple different ways. And one of the most important ways is to identify a form of syndromic hearing loss before it is clinically apparent. All right? So these are otherwise called non-syndromic mimics, but the most important of these is Usher syndrome, right? Usher syndrome, which presents with sensorineural hearing loss years to decades before any visual changes. We can also identify Alport syndrome before any manifestations of kidney disease. And then for certain syndromic causes, you might suspect these, but doing the genetic testing can refine exactly what type of that syndrome is present and alert you to other syndromic associations, such as for brachiotorenal or Waardenburg. Another category of genes that directly affect management are those that are strongly associated with progressive hearing loss. The most important of these is SLC26A4, which is associated with Pendred syndrome and enlarged vestibular aqueduct syndrome. TMPRSS is the most common causes of adult onset or postlingual onset sensorineural hearing loss. And other genes such as myosin 15A and TECTA can have progression depending on the exact variants that are identified. And actually for all of these genes, the specific variant that is involved can affect the likelihood of progression. Finally, and these are the most obvious ones, there are some genes that, if they're identified as the cause of hearing loss, lead directly to differences in how you treat them. The most obvious one is otoferlin, and Eliot will talk about that more later. But PAL3F4, right, is the gene associated with X-linked Stapes-Gusher syndrome, and that can really affect exactly how and when you would consider a cochlear implant. So what I'd like to do at the end here is just to briefly run through how you read a genetic testing report and get from that genetic information to affecting your understanding of the phenotype and your management. And we all look at scans all day, and we know how to interpret those beyond what the report says, and there's no reason why you can't all do this for genetic testing reports as well. Just like with imaging reports, if you don't want to read the whole thing, it will tell you whether it's positive or negative, right? And that will tell you whether, according to best practices and best diagnostic criteria, you have a genetic hearing loss. But the first thing, if you want to understand it more, is to look at the name of the gene, right? In this case, it's SLC26A4. There's always a table of the variants that were identified in the testing report, and in this case, there were 2 variants in SLC26A4. The second thing that I look at is the mode of inheritance, right? So if it's autosomal recessive, you need to have 2 variants or 1 homozygous variant in order to be considered diagnostic. If it's autosomal dominant, you just need 1. And then together with the inheritance pattern, you look at the zygosity, right? So you want to see, is this a homozygous or heterozygous variant? In this case, it's compound heterozygous. There's 2 heterozygous variants. The variants are always going to be classified as either pathogenic or of unknown significance. Obviously, the pathogenic variants have more certainty in determining the genetic diagnosis and knowing how to interpret the phenotype. The final thing that I do always look at are the specific variants. For SLC26A4, there are variants that are associated strongly with Pendred syndrome, which are often more rapidly progressive, some that are associated with enlarged vestibular aqueduct syndrome without Pendred that can often be less likely to be progressive. So when you look at all of those 5 things, that tells you in more detail what your genetic diagnosis is. This is a child who had SLC26A4 associated hearing loss, and the variants were associated with Pendred syndrome. And these genetic diagnoses we've actually found do corroborate the diagnosis of hearing loss, such that families are 2.5 times more likely to proceed with hearing aid or cochlear implant intervention, even after adjusting for clinical and demographic factors. And this particular child did have a mixed progressive asymmetric hearing loss, which matches with the expected, this is the phenotype which we expect from that genotype. And when we got an MRI, it was confirmed that this child had bilateral EVA. And in this specific case, this was a kid who presented at birth with a moderate hearing loss and was not a cochlear implant candidate. But because we got genetic testing at 3 months of age, we were able to track his behavioral audiometry very, very closely in that 6 to 9 month age, get him implanted early when he progressed early, and now he's 4 and in the 90th percentile for speech and language. So if you look back 15 years ago, genetic testing would tell us, often tell us an answer and provide us information for family counseling. But really now, genetic testing helps us understand the answers to all of these questions. And so I'll hand it off to Dr. Cushing. Thank you.
Excellent. I was tasked with the question of when should clinicians order testing and when should we have genetic counselors involved. So we'll just have the slides up. There we go. All right. Oh, perfect. All right, a few disclosures and an amazing team back home. So I'm going to start off really simple. And my general answer to this question is this, always. And what I'm going to do over the course of the next slides is explain to you why I think that's the case and bring out some relevant examples. And I took a few liberties with this because I think there's going to be some new concepts in here just in terms of where we might be heading in terms of genetic evaluation. So, as Dylan so beautifully said, this is what we can think about in terms of, a laundry list of why we should care about etiology. And today we're going to focus on genetics, but I think thinking about etiology is a much more important variable. And certainly I think of how we look at this from the lens of a clinician might be different than the lens of a family. And I've certainly heard the words come out of my mouth, well, it's not going to change what I do, so why would I care? And I can imagine that many of us in this room have thought that. But I think for families, even if it doesn't change what you do, it matters for some of the reasons up here. Now, I think the answer is always, but the answer is also early. And that's the story I'm going to tell you today, is why it matters in terms of our ability to reduce the developmental impact on children with hearing loss. And these are the things that we're going to talk about is if you have early access to an etiologic diagnosis, whether that be genetic or otherwise, can we actually make our systems better and reduce the developmental delay to amplification or implantation? Now, I only look after children, and so I always come at it from the lens of development. And so we know that hearing loss is a developmental emergency. Deafness is not good for the brain, and any additional day with deafness is not a good day for the most part. And one of the things that we have tried very hard to do as cochlear implant surgeons is think about the sensitive periods for hearing loss in children. And this is, I think, how we think about it as surgeons. If I just do X, whether that's implants or that is hearing aids by this date, 2 years, 12 months, put whatever number you want there, then we're okay. But the reality is that development is like this. Every day matters. And we have good evidence to suggest that earlier is better, with some of the best evidence coming out of the beautiful Lochi study in Australia. And so one of the things that we really care about in our program at Sick Kids, and I know that you care about in your programs, is getting children implanted as early as they can be. And here is our historical cohorts of implants over the years, and we've more recently added an under 9-month category, although it's small. And we could focus on our successes, but what I want to focus on today are the kids who should be implanted younger but aren't, for any number of reasons. And we looked at our program, okay? And what you can see here is children at the top who were implanted early, under 12 months, children who were implanted between 2 and 3, and children who were implanted, between 1 and 2, and then 2 and 3. And all of those little dots are all the things that you have to do before you get a cochlear implant. There's a lot of steps. And when we look at delays, they always come back to the same thing, is that confirmation of the sensory neural hearing loss is the biggest factor. Once that happens and you get into our programs, things really do go along quite quickly. But that is the delay, and there's lots of reasons for those delays. And so that's where we want to see, can we make this better by inserting an etiologic assessment early on? And we know that newborn hearing screening is far from perfect. Our screening program in Ontario has lots of holes in it, and certainly there were even more holes when COVID came and it was deemed a non-essential service. And so we know that we miss babies and children that need to be identified. We also know that there's progressive hearing loss. And so this was a concept that came through Newborn Screening Ontario, and what we looked at doing was using etiologic risk factor screening to enhance our newborn hearing screening program by adding genetics and CMV. So that's what I'm going to take you through. And so I'm not going to talk a lot about CMV other than to say we've looked for it universally in children since 2019, and these data are recently published, showing that we have a huge cohort of children that we're now surveilling for progressive hearing loss. And this matters because when we look retrospectively at a cohort of children with CMV-related hearing loss, what we see is that a lot of those ears passed their newborn hearing screen, and by virtue of that pass, they had delayed diagnosis in their hearing loss, so it matters. But the other thing is that children can also have duality, and this is why I say always and early, because certainly my genetics department would love it if I didn't test genetics on children who had congenital CMV. They always ask me why I'm doing it, and this is the reason here, is that there's lots of overlap in these relatively common presentations in children with a hearing loss phenotype, so always and early. And so let's get to the heart of the matter, and that's what we began to do in 2019, is that we instituted a limited but universal genetic screening for every baby born in Ontario, regardless of their hearing status. And we focused on a small number but highly penetrant mutations in GJB2 and then a few other ones in SLC26. This is by no means perfect, but it was a start. And the reason it was important to start is that, again, the systems and the care pathways that you need to go along with universal screening are complicated. And so we now have that part down to a science of who calls the family, what happens next. And so this is what we have found, and there's lots of information on this slide, but what I want to point out is that this is a consented process, and 98.8 families said, yes, do genetics on my baby. And so you might think that that would have been an issue, but this was universally accepted by families as a value add to their newborn diagnostics. And so does it help? Is it actually going to make things better? Because there's certainly cost associated with it. And so to figure that out, what we did is we looked back at a retrospective cohort of children born before screening with these common variants. And so to see, okay, how effective would it have been had we had screening at the time? And so a lot of those kids are identified on screening. So in many ways, it's double dipping, except when screening doesn't work. But there were also a number of children who passed their newborn screen, okay? And a number of children who had screening data unavailable, both who were born in Ontario and who were born outside of Ontario. But if we look at the genetic screening data, these would have been the individuals who would have been picked up. And again, it's a small cohort of all mutations, and so that's why it's not everybody. But we picked up children who would have been identified as well as children who passed their newborn screening. And so we decided to take this one step further because we now had cohorts of children who had a genetic etiology. The same is true of CMV, but I'm just going to show you the genetic data. And we watched how they navigated their way through our cochlear implant programs. And this is what we saw. Everything happened earlier. They got their diagnostic ABR earlier, they got their MR, they got their cochlear implant earlier, and we have similar data for the kids with congenital CMV. And that's because somebody picks up the phone. And because many of our kids who screen positive for hearing loss on newborn screening don't actually have permanent hearing loss. And so these children appropriately go to the front of the queue. This is some of Dylan's data, which also I quite love because it demonstrates that knowing the etiology, particularly if it's genetic, changes what families do. So their acceptance about wearing a device changes when they know the etiology. And we certainly see that in our clinic, is that the families process as how they work through their grief is different when you're sitting there both with a physiologic cause as well as a phenotypic cause for the hearing loss. All right, almost to the end, and then we're going to get to Eliot's exciting stuff. So when should a genetic counselor get involved? And I've kept this appropriately simple as well. And where possible is my answer. And I think, this is actually, our genetic counselor helped me put this together because I wanted to make sure that I came at it from their perspective and not mine as a surgeon. And I think that they're trained to do this. They likely do it better than us. However, they should not be involved at all cost. And so there are systems issues where this could lead to a significant delay in etiology detection, and so, or you don't have the resources to do it. And so I think that, certainly I order the genetic testing and I work with an amazing genetic counselor who then picks up the pieces depending on what the result is, but I don't involve them in that pre-test counseling, just because, again, there's a delay in doing it. It's certainly not involved, when we screen universally. I think that they can be invaluable and have an amazing skill set, particularly for the post-test counseling. They have way more time than we do and way more knowledge than we do in order to counsel families through these difficult questions in terms of additional testing, family members, recurrence risk, and all of that. And so I do think where possible, and hopefully the access to genetic counselors with this expertise is going to continue to grow and grow so that it's easier. But I wouldn't wait until you have someone to send them to. So in summary, I think that identifying etiology is immensely important to the point that it can reduce the developmental impact of sensory neural hearing loss on children, because at the end of the day, regardless of the therapy that we're going to use, early identification is the foundation. Our diagnostic algorithms continue to evolve. Dylan alluded to what we did when we were trainees, and it's changed. And there's also this nuanced relationship where it drives therapy to know the etiology, and it is also driven by therapy. We're testing more because now we have therapies, but we need to continue to test so we continue to develop therapies. And there were many amazing talks today which would have been immensely enhanced by knowing the underlying etiology in those cohorts. So I think when we're reporting on our data, it helps us a lot to understand why these individuals have their hearing loss. So I'll finish there and pass it over to Eliot.
Thank you, and thank you for having me. So I'm going to summarize all of gene therapy for hearing loss in 10 minutes, I think, so it should be easy. So I'm the site principal investigator at Boston Children's Hospital for both the Eli Lilly, also known as ACUOS, and the Decibel Regeneron trials. As far as I know, I think we're the only site in the world that's running both trials. So I have experience in both of them. I, however, am not speaking on their behalf today, just providing an overview. You saw a talk from Dr. Hansen earlier, and I think there's going to be a talk after us from the sponsors. So this patient, his name is Miles, and he really changed how I look at patients with hearing loss when he presented to my clinic when he was 4 months old. The mom actually asked that I use his photo and his name so he can help teach people. I'm a cochlear implant surgeon. When I see a patient like Miles that has bilateral profound hearing loss, I'm excited to put in cochlear implants. They work great. There's decades of experience. Miles's mom walked into my clinic and she said, I do not want cochlear implants. I don't want one cochlear implant. I don't want any cochlear implant. I want gene therapy. Miles has otoferlin hearing loss, and it was the first time that I looked at a cochlear implant as a less than, and so he's one of our first trial patients. The world is really different for these families now because they can see a world where they don't need a cochlear implant for their child. So I kind of think about where we are in the progress for gene therapy in this overall sort of scheme of diagnosis and improved understanding of hearing loss leading to improved treatment. So, an improved understanding of cochlear physiology and CT scans then led to first hearing loss genes identified in first genetic testing in 1999, the first gene panels in 2010. The first cochlear implants were put in the 60s, followed to the 80s, and then ganciclovir, which is a pill we can use for hearing loss, which is crazy when you think about it, and now gene therapy. So the diagnostics and the treatment and our understanding of hearing loss go hand in hand over decades, and you need to have an understanding of the physiology to lead to the treatment. But really, this is kind of where I think we are. So I was able to find this from Dr. House presented this in 1973 at the AOS meeting in St. Louis. I certainly wasn't there. I don't know if any of you were there. Maybe some of you were. But this is kind of where I think we are with gene therapy. He said at that point, we are not convinced that the present system cannot be improved in any of its aspects. So essentially saying we have to improve everything. And then also saying, what's the best electrode system? What's the best electronic circuitry? A lot of questions. I would say that's where we are right now for gene therapy as well. So the overview about how to do gene therapy, if you break it down, you first need to understand the molecular mechanism of hearing loss, choose the viral vector and promoter, and choose the surgical approach. And we don't know the best way to do any of these steps at this point, I would say, but we're working on it. So I'm going to go through these. So the molecular mechanism for hearing loss for the trials that we're doing right now are for otoferlin hearing loss. And so otoferlin is this little green protein that's shown there at the ribbon synapse that allows the vesicle to fuse with the membrane. The reason that there's 2 companies in the United States, 1 in Europe, 2 in China, that are focused on otoferlin is all the components are there. And so once you can restore that little green protein, then everything should work again. The downside to otoferlin is it's not super common, okay? So it's actually, here it's about 2% of cases in these 2,400 of our patients that we looked at. But, I think for a lot of reasons it's a good candidate to start with because we do know the molecular mechanism. Then you have to choose the viral vector and promoter. So specifically for hearing loss, we talk a lot about adeno-associated virus. Okay, it's been shown for years to be safe. It has low immunogenicity, has very long-term expression, and it can be very targeted to exactly the cells that you're interested in the inner ear. The downside is the carrying capacity is pretty low, which I'll talk about. I will say that the benefit of AAVs is there's many serotypes of AAVs, and AAV1, ANK80, some derived AAVs are good for the CNS and the ear and the retina, but these are now used all over the body. So this is what an adeno-associated virus sort of looks like. There's a capsid, and that carries viral DNA. The viral DNA includes a promoter, which allows expression of the gene. The way to think about this is like a suitcase carrying a textbook. So the suitcase is the viral capsid, and that allows the textbook to get into the cell. Now, I would say that, in the case of adeno-associated virus, because it's quite small, you actually need two suitcases and 2 textbooks because it can't carry the full otoferlin gene. And so this is one example. There's many different examples of how they do this, but essentially part of the otoferlin gene is in one viral capsid and the other is in the second viral capsid. So you actually have to use a mix of 2 viruses to get in the cell to express the correct protein. So this kind of schematic shows the AAV life cycle. I'm so glad Dr. Kim talked about the CRISPR gene editing because that was an incredible story. but that is not what we are doing here, okay? So I equate hearing loss gene therapy closer to like the COVID vaccine than gene therapy. We're using a virus that goes into the cell. There's no genome editing. The virus specifically does not integrate into the human genome, because if that happens, then you can increase cancer risks. So these viruses have been chosen and selected for decades of mouse studies and preclinical trials to be used and to be safe and stable and allow what we think is permanent expression of the transgene. So otolaryngology is actually a little bit behind. So actually, gene and cellular therapies are part of modern medicine. So I looked, and the FDA currently has over 40 different approved cellular and molecular therapies. And actually, there's 6 FDA-approved adeno-associated virus gene therapies already. The most closely applicable to us is Luxturna, which is for Leber's congenital amaurosis, an eye disease, and that was actually approved in 2017 and has been shown to be very safe. So then we have to choose the surgical approach. And again, this is part of these trials. We don't know the best way to do this. The trials in the US are focused on, both of them perform a fenestration, because the cochlea, as you know, is a closed system, and inject through the round window. One trial does a stapedotomy approach, where the perilymph will actually egress through the foot plate, and the other trial does a lateral semicircular canal fenestration to allow egress. The trials in China don't do a fenestration at all. So this is still an open question in our field. So, the only data that's actually published is from the Chinese studies, and so I'll just show you some of that here. This is some pictures of their surgical approach, which they did a transmastoid approach and injected with a needle through the round window membrane. And this is what the data looks like. So you can see pre and then up to 3 months post-operatively for patients. And this is from one of the studies. This is kind of similar to what Dr. Hansen was showing earlier. You have some patients who essentially have returned to normal hearing function, whereas other patients maybe don't have the improvement as you would expect, and maybe would be hearing aid candidates, essentially. And this is from the other study in China that was published last year. You can see that this patient here, after gene therapy, essentially has normal hearing. This one is more moderate hearing loss, and then the one here essentially is a non-responder. And so when I talk to patients that we're enrolling in these clinical trials, I say to them that the key takeaway is that they're safe, okay? So that's the main concern that I have, is that these viruses are safe. The hearing outcomes are impressive, but they seem to be a little bit variable at this point, I would say. The biggest concern that I had is I was worried we were going to inject this virus and we would not be able to perform a rescue cochlear implant afterwards. That has been done now, and there's been a lot of CT scans that have been done in China on these patients after. There doesn't seem to be an intense inflammatory response, like a sort of meningitic response or ossification that would prevent cochlear implantation. So to me, that's really important, that if this doesn't work, we can use a cochlear implant. So these are the key takeaways for me. So if you talk about the next therapeutic targets, there's pluses and minuses to everything. So just really to summarize, hundreds of papers worth of data. The next sort of genes that I think about are genes like GJB2 that are incredibly common, have a huge patient population, but we're a little unsure whether we'd be able to actually correct the problem before all the hair cells die in GJB2 patients. There's a recent study that showed that maybe this could work, but it's a little bit unknown. But maybe GJB2 patients that are having progressive hearing loss would be candidates. Clarin-1 and other Usher syndrome patients seem to be a viable target. Those are hampered because it's a smaller patient population, so it's harder to do the study. I think stereocylin is really interesting. This is a mild to moderate sensorineural hearing loss, usually treated with hearing aids. Some days in my clinic, I'll see 4 patients with STRC hearing loss now. I think that they would be great candidates for gene therapy, because if you could tell a parent that they do 1 injection and they never have to wear a hearing aid again, I think a lot of parents would go for that. But overall, this is our cohort of 637 patients. There's all these different forms of hearing loss. And right now, I think of gene therapy as a tool in the toolbox. So it's not going to replace everything that we're doing. It's not going to be replacing cochlear implantation. And I'll just finish up here with important considerations. So whether we should be doing bilateral versus unilateral, Because I live in Boston, people are coming in and bring me reams of journal articles that they've read and printed out, and they want to know when their genetic mutation is going to be in a trial and whether they should save an ear. So we're going back to this unilateral cochlear implantation phase again. And I have several families that are saving an ear for gene therapy, even though the trial's not even available yet. And I tell them I think they should do bilateral implantation, but it's an interesting discussion. We have no idea what the rehab is going to be like for these patients. This is not part of these trials. These are phase 1-2 trials. And so that's a big question in my mind. And then this is not a life-threatening disease, and so we have to make sure it's safe is the most important thing. I worry about our healthcare system and that hearing loss is a very common genetic disorder. And if we start making these, how we're going to scale this to 1 in 500 children that have severe to profound hearing loss. And any genetic therapy requires an accurate genetic diagnosis ultimately. So with that, I'll skip through that and then say thank you for having me.
Thank you for those terrific talk. Do we have time for, okay, we have time for a couple of questions from the audience.
Comment to Eliot. STRC is not a good target. People with STRC have stable 40 dB sensory neural hearing loss their whole lives with normal speech discrimination and quiet. They do incredibly well with hearing aids. So if we could get gene therapy, if we could prove that gene therapy had the same risk as stapedectomy, then it would become a viable treatment. But until we actually know that, we can't put those years at risk. If there's a 20% incidence of deafness from the injection itself, it's an inappropriate gamble.
I completely agree, and that's why I put it up there. I think it's a future target that could be very viable, yeah.
Dr. Shearer, I have a question for you as well. You presented, the graphs showing the range of outcomes. But my understanding, and please educate me, is that that's threshold. One of the things I'm interested in knowing, do we have information yet regarding speech perception and what is the quality of the speech perception after gene therapy?
Yeah, that's part of the trial, and we have to wait till things are released. But I think, do you want to talk about your patient?
Yeah, so that has not been published yet. We have one patient in our practice who had an injection in one ear, implant in the other ear, and her speech recognition are equivalent in the 2 ears. This is over a year after her injection. So
that's fascinating.
we're getting there.
Wonderful.
Yeah.
But that is also a little different than someone who doesn't have an implant. Does the implant ear influence your outcome?
Yeah, it's like a second side cochlear implant.
No, this was with her CI turned off. She has auditory and speech performance in her injected ear alone.
But it's still different.
Of course, it's different.
But that's fascinating. Yeah. So thank you for sharing.
Yeah, but
publication.
That's his own patient that he's caring for clinically. So I think that's a little bit. That's why I let him answer that.
Sujana Chandrasekhar from New York. For those of us in private practice without access to a lot of gene therapy, gene counseling people, what is the best test for us to order? What companies test, or how do we streamline this process for our patients?
So the easiest way to do it now, and I took the slide out, but I should have kept it in, is there's something called the Resonate program, which is with AOS, and then I'm forgetting the name of the other program with Decibel. There's sponsored free genetic testing programs, and now hundreds of people a year are using this. If you Google it, they do pre-test genetic counseling. They order the testing for you. They have a geneticist that orders the testing for you, and they do post-test counseling. Many people are using that now, and it's covered by the company. The company doesn't keep the data, but it's called sponsored genetic testing. As far as the other companies, GeneDx or Invitae or whatever, I helped make the otoscope test, but I think they're all the same at this point, equivalent.
And you can send children and adults for this?
Yeah, so the Resonate program, you can do any person less than 45 years old with sensory neural hearing loss. The program with Decibel, it's just ANSD still at this point.
Thank you.
Yep. It has to be bilateral in both cases, yeah. For the Resonate program, I think it's moderate to profound, and for the Decibel program, it's ANSD. Yeah.
And then even without the sponsored testing, for just the standard commercial testing, at least the company that we've been sending off GeneDx. They do the benefits investigation, so you don't have to get pre-authorization. And you can either have the company send the testing kits home, and we always get either buccal or saliva tests, so they don't have to get a blood test. We actually do the buccal swabs in the clinic, so that they don't even have to have the extra step of. So when we have a new ID of a kid with sensory neural hearing loss, we do the buccal swab and send off the test immediately.
Yeah, and in Massachusetts, it's covered 90% of the time now by private insurance. So any kid with any sensory neural hearing loss, and then the public insurance covers it. I know in California, it's covered by public insurance. But also the out-of-pocket maximum that like GeneDx charges, if insurance doesn't cover it, is like $300. So, it's become very cheap and accessible, I would say.
Thank you so much.
The last question goes to the president.
I have a question. Dylan, thank you. When you listed the 5 different categories of how to read a genetic test, and so this is a 2-part question. Number one, just like radiology, when you get a radiology test, there's at least probably once a month I write to the radiologist and said, hey, you missed something. How good are these reads that come out from the test, in the sense of is there variation of how you interpret this, like a radiology report, or so that's number one. And then the second thing, you talked about the class of, this is significant. And what I'm finding is I order a lot of genetic tests, and they come back as, questionable. And then we had a talk by a genetic counselor. Maybe you guys could give some input to this. To my understanding, there's somebody out there in the world that decides if a gene is associated with a clinical. Who does that? And I guess there's like 5 categories. So maybe you could help me understand how that classification system actually works.
Yeah, those are great questions, and that really is the crux of the genetic diagnosis. Is that it is, it's not black and white, right? There are some that are very, very clear and definite. There's a large gray zone, and the uncertainty can come in 2 ways. One part of the uncertainty is this actually the causative gene and variant? And the other uncertainty can be, what is the prognosis associated with that specific gene and variant? And yeah, that is determined in part by the genetic testing company. They more focus on that first part, right? Is this definitely a genetic, the causative gene variant? And there are clear guidelines on that based, that have been vetted by people like Eliot and genetic counselors and geneticists. But the second part of it, right, what prognosis does that entail? That comes from what we all do and the acquired body of literature and science, and the more people that we see with these variants and these genes, the better understanding we'll have, just like everything else we do in medicine.
I would just say one other point is that if you just send someone for a scan and don't give any clinical information, that's going to be difficult for the radiologist to interpret, right? So as much information as we can include is helpful. And all of the companies have a number that you can call, and you can speak to a genetic counselor or a geneticist, and you can provide more clinical information. They can guide you if it's not clear based on that. So in the report, it's helpful to put 2-month-old with bilateral severe to profound deafness, because in their interpretation at the end, they'll say this is consistent with bilateral profound deafness.
I'm going to take the president's prerogative and just follow up with the question. Because, I'm doing a lot of, not a lot, but it seems like all of the genetic tests I've done have come back with something, although it's never significant. And I've had this discussion with Richard Smith. I've tested unilateral hearing loss in kids and adults, and I come back with there's an abnormality, but yet you're not supposed to test those kids, and yet then they find genes that are associated with hearing loss, and then they say, but we don't think it's related, or we're not sure if it's related, right? And so in those situations, back to kind of, Eliot, to follow up with what you're saying, how do we get these kids or these patients, enrolled? Or, I think the companies tell me that they keep a list of these patients, but, if I do a patient and you do a patient and somebody else does a patient, because sometimes you read the papers that they cite and there's like, oh, well, there's been 3 families identified with this gene. And it's like, well, is this the 4th family? Or, how do we get to that?
Yeah, they all have a responsibility to review these. So first of all, they go into databases. They have internal and external databases. And generally, these companies once a year actually will go through and review everything and then update it. And they'll send you an updated letter. They should, like any of the reputable companies which are testing in the United States will do that.
And then from a practical standpoint, right? I only give strong recommendations and prognostic, predictions on very strong findings. And, you have a conversation with the patient or the family and say, well, this might be suggestive, or this might, give us some more information. It's not definitive, just like we have conversations with anybody else. But this is just going to be getting better and better, and we're going to have more and more confidence in our ability to act on this genetic information in the next 5 to 10 years. And so getting all of us more more used to doing the testing and seeing these results. Just think about all the scans that we were getting 20, 30 years ago. That's where we are with starting to do genetic testing.
I think we can go on and on and on, but we have another program following us, so we'll end here.
Yeah, thank you all very much. I think this is one of those topics that probably in 2 years we'll have a whole lot of other information to discuss. So again, thank you all for your work and for the presentation. This actually ends the CME portion of our talk, because